Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This podcast provides observations and commentary on the JCO article entitled A Randomized Double-Blind Phase 2 Study of Regorafenib in Patients with Metastatic Osteosarcoma by Davis et al. My name is Brian Van Tine, and I'm Associate Professor of Medicine in the Division of Medical Oncology at Washington University in St. Louis and the Siteman Cancer Center. My oncologic specialty is sarcoma. Osteosarcoma is the most common type of primary malignant cancer of bone. It frequently occurs in children and adolescents. It can also be found in older adults around the age of 70, but unfortunately, although rare, can be found in patients of any age. Thus, osteosarcoma is a disease that not only do pediatric oncologists need to know about, but also the adult oncologists. Osteosarcoma primarily occurs at the metaphysis of bone, in regions of rapid bone growth, and in bone-forming cells called osteoblasts. Various risk factors for the development of osteosarcoma include underlying bone pathologies such as Paget's disease, prior radiation treatment, and genetic predispositions due to mutations such as Li-Fraumeni Syndrome, caused by mutations in TP53, or in retinoblastoma patients. Currently, in the curative setting, osteosarcoma is treated with chemotherapy with cisplatin, doxorubicin, and high-dose methotrexate, which is then followed by surgical resection of the tumor. Patients who relapse with metastatic disease have limited options. Regiments such as ifosfamide with etoposide and gemcitabine with docetaxel are used with an expected 4-month progression-free survival of only 12%. But the standard of care of osteosarcoma has really not changed in 30 years. This is where the Sarcoma Alliance for Research and Collaboration, or SARC for short, comes in. SARC is a nonprofit organization dedicated to the development and support of research for the prevention, treatment, and cure of sarcoma. It is a collaborative group comprised of leading sarcoma physicians dedicated to performing clinical trials in rare diseases. It is their 24th trial that is the subject of this JCO article that accompanies this podcast, where Dr. Laura Davies and colleagues report their findings of a randomized, double-blind, Phase 2 study of regorafenib in patients with metastatic osteosarcoma. This trial took place across 12 U.S. centers between 2014 and 2018 and enrolled 42 patients between the ages of 18 and 76. Once again, the age distribution highlights that osteosarcoma is not only a pediatric disease, and that there is a dedication to rare disease research to accrue to rare clinical trials because of SARC. In this trial, patients were randomized 1-to-1 to either regorafenib or placebo in a 28-day cycle, and responses were assessed using RECIST version 1.1 every 8 weeks. At the time of progression on placebo, patients were allowed to cross over to regorafenib. Following the release of the European REGO-BONE trial, a study of similar design that showed a significant benefit of regorafenib in osteosarcoma patients, an independent data safety and monitoring committee was convened by SARC due to concerns regarding continuing enrollment of patients on a placebo-controlled study. The committee recommended closing the study after enrollment of 42 of the 48 planned patients. Overall, here's what they found. At the time of analysis, they found that the progression-free survival was 3.6 months for regorafenib and 1.7 months for placebo, with a hazard ratio of 0.42 and a 95% confidence interval of 0.12 to 0.85 and a p-value of 0.017. Given the crossover design, there was no survival seen, and the overall survival's p-value was 0.62. In addition, no new safety concerns with regorafenib treatment were identified during SARC-24, and adverse events were generally managed with dose reductions. Notably, the mean dose at the end of the trial of blind treatment was 120 milligrams. Taken together, this makes this the second trial to clearly show benefit for the use of single-agent regorafenib for the treatment of osteosarcoma. Highlighting the issue with the use of RECIST to evaluate tumors that make bone within their matrix, only 3 patients on regorafenib achieved a partial response. Whether this is a cytostatic response to regorafenib or part of bone biology of osteosarcoma will need to be determined in future work. There are a number of meaningful observations that come from this trial. First and most obvious, Regorafenib is active for the treatment of osteosarcoma, and it is an oral formulation. While this time is not listed in the NCCN guidelines, this publication will make the second randomized trial supporting its use. I would hope the guidelines soon change to reflect these publications. Next, there is also a very important paper published in JCO in 2016 by senior author Katie Janeway. It was a summary of 7 negative phase 2 trials from the Children's Oncology Group, or COG, that established the natural history of unresected osteosarcoma, and it was found to have an event-free survival of 12% at 4 months. They conclude that this evaluation provides a baseline for disease progression in a population of children and young adults with refractory recurrent osteosarcoma that can be used as a comparison for the design of future phase 2 trials in osteosarcoma. In the current trial and in the REGO-BONE trial, the placebo arms of those trials demonstrated a similar rapid progression of 10% at 16 weeks in SARC-24 and 0% at 12 weeks in the REGO-BONE trial. Thus, these become the 8th and 9th trials with a placebo arm that supports the data of the 2016 JCO publication that stated that the progression-free survival of placebo for the treatment of osteosarcoma is now well established. To be fair to the authors and to be clear, SARC-24 was started 2 years before the Janeway publication, but these findings are supportive of stopping placebo-controlled trials in the phase 2 trials of osteosarcoma. Once again, the authors are to be congratulated for their findings, which I find practice-changing. Their dedication to rare cancer research is benefiting patients that agree to participate in clinical trials. Working together, they have identified an active agent for the treatment of osteosarcoma. It will be interesting to see what the next steps are for the SARC team, as they have proposed combination studies based on regorafenib in their discussion. Finally, rare disease research and clinical trials in sarcoma are desperately needed to improve the outcome of our patients. We would like to thank JCO for highlighting the work of Dr. Davis and colleagues and the Sarcoma Alliance for Research and Collaboration. This national organization has sites across the country where sarcoma patients can enroll in clinical trials. A list of adult and pediatric sarcoma referral centers and the list of clinical trials are available at sarctrials.org. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.